My name is Philip Mons. I'm a professor of healthcare and nursing science, mainly located at the University of Leuven in Belgium, but I do have a joint appointment at Gothenburg University in Sweden, and that explains why a Belgian ends up with a Swedish project. I'm happy that we are the spokespersons for a large team that is involved in the different STEPSTONES projects, and we are happy to share our insights with you. And I'm happy to do this with my colleague Ewa-Lena Bratt.
So I will introduce myself as well. My name is Ewa-Lena Bratt. I'm a pediatric nurse, but I'm also a professor in nursing science. And I work at the University of Gothenburg in Sweden and also at the Queen Silvia Children's Hospital in Gothenburg, Sweden as well. So I'm looking forward to this presentation, Philip. I give the word to you first.
So the title that we were given was the STEPSTONES Research Program, Effectiveness and Implementation. And the term program is important here. Something started with a specific project, but in the meantime, it grew bigger and bigger. And now we really can say that this is a research program. And it will become clear during this talk. STEPSTONES stands for Swedish Transition Effects Project, supporting teenagers with chronic medical conditions. We are not saying anything new when we say that transition is a complex intervention. You heard it from the other speakers today. Complex interventions are defined as interventions that are built from a number of components that may act independently and interdependently. The active ingredients of the intervention is unknown or difficult to specify. It is like cooking. You have different ingredients and you seldomly can say this is the ingredient that determines the taste. It is the combination of the different ingredients that makes the recipe, that makes the dish. And knowing that transition programs are complex interventions, we need to approach them as such when we are evaluating it. In this respect, the Medical Research Council in the United Kingdom, they have developed different frameworks on how to approach and how to evaluate complex interventions. And this is one of the frameworks that we used at that moment. What the MRC indicates is don't just jump on doing a randomized control trial. You need to do some preparatory work, because if you're just jumping to an RCT, you probably are making the wrong choices, not having a good fit between the outcomes, between the intervention and such, which makes you bound to have problems in terms of effectiveness. So we really did indeed a lot of preparatory work. Studies have been conducted on the experiences of people before the transfer to adult care, after the transfer, what they missed, how the parents experienced this project, how the parents experienced this transfer from pediatric to adult care. This all gave valuable information. And of course, we do have a lot of information, but doing this kind of research in Sweden helped us also to understand what would work in a Swedish context, what are aspects that are needed in this Swedish context to make sure that we could tailor the intervention towards the local situation. And local, I mean the national situation in Sweden. Then we came to the phase where we wanted to construct, when we wanted to build up the intervention. And again, this is not something that you do on a Sunday afternoon at your kitchen table. It requires a lot of work, a lot of preparatory work, a lot of insights, discussions, and so on. And there are methods that you can use for this. We use the methodology of intervention mapping. And what is interesting about intervention mapping, it is a very staged approach. We first started with the question, what are the problems with transition? What are the problems that people are having with transition? What are their health problems? And based on literature, based on a preparatory data that we had, we came to the health outcomes that are problematic in our patients are reduced well-being, reduced biopsychosocial functioning, and an increased healthcare utilization. We had a slight extra attention to congenital heart disease because that's what we had in mind for the very first time, but we wanted to be as generic as possible. Then the next step is from these health outcomes, you look at what is the health problem. And to a certain extent, you make sure that there is a good link between the health outcomes and the health problems. What were the health problems that we identified? Prolonged dependency on parents, lapses in cardiac care, and not receiving cardiac care in most appropriate setting. Then intervention mapping says you have to look at what are the factors, behavioral factors and environmental factors. Once that you have identified this, you try to identify the determinants for these factors. You can imagine this takes time to come to this. Once that you have developed this logic frame, so to speak, then you do the so-called intervention factors, because if you work on the determinants and you flip the model, so to speak, you know that working on these determinants will impact on these factors, will impact on the health problem, will impact on the final outcomes. So it is really building a model that kind of gives you an indication on how could this intervention work. And using this intervention mapping strategy, we came to these 8 components, and we call it components of the STEPSTONES transition program, but you could also call it the ingredients of our recipe. What are these components? We were working with a transition coordinator. You need someone who is really making sure that all the noses are in the same direction. A written person-centered transition plan, providing information and education, availability by telephone and email, information about and contact with the adult clinic, guidance of parents, meeting with peers, and transfer to the adult care. So these are the key factors, and we can also call them the stepping stones in this transition phase. What is also a very crucial element is that everything that is done in the STEPSTONES intervention is guided by the heads. It's the red thread, so to speak, through the interventions. Because if we really want to make sure that we are dealing with those things that matters to adolescents, we need to have a good insight in how is their life looking like. And heads is a crucial element in this. Interesting enough, when you go to the logic model and when you look at the outcomes, and especially when you are designing a study on that, you have to think on what could be the outcomes that we are using for the trial. And to a certain extent, a lot of the outcomes that matters to transition are rather distal outcomes. Outcomes that you can achieve in some years, but not necessarily in an immediate way. And that is problematic when you're designing a trial, because in a trial, you need to deliver in 4 years or 5 years, and what can you achieve in 5 years with these patients. So therefore you need more proximal outcomes. And a proximal outcome, after a lot of literature research and discussion, we came to the concept of empowerment, because we really wanted to empower the patients. And we know from literature that an empowered person is likely to have a better well-being, to have a better biopsychosocial functioning, and to have a more appropriate healthcare utilization. So empowerment is a key element in what we want to achieve with our patients, and it's a key outcome, the primary outcome in the trials that we are conducting. Like I said, STEPSTONES developed from a research project to a research program. And in the meantime, we have finished the STEPSTONES CHD, congenital heart disease trial, and Ewa-Lena will talk about this more in detail. Right now, the STEPSTONES diabetes randomized controlled trial is ongoing, and we hope that by the time that the next conference on transition is organized, that we are able to shed some light on the findings. But of course, there are also other things to do. And we started, for instance, with what we call the Digi STEPSTONES. It was already indicated this morning by Imelda, like what is the future? And is it possible to deliver transitional care from a distance? There was a high need during the pandemic, but there is, even beyond the pandemic phase, it's not always easy to get people to the clinic, especially not in large countries where there is a huge travel distance. How can we make sure that we make transitional care more accessible? And would that be as effective as when you have a face-to-face contact? That is what the Digi STEPSTONES project is aiming for. And then we have the STEPSTONES Implement project. Taking all the evidence together, we know that it works. And we don't have to convince anyone here in the room. But how can we convince other people? And how can we make sure that the translation from research to clinical practice is really working? What are context factors that play a role? How to facilitate this? Then implementation science comes into play. And that is actually what the aim of the STEPSTONES Implement project is for. I give the word to Ewa-Lena now, who will guide you a bit more through the RCT on congenital heart disease and on the implementation project.
Thank you, Philip, for this lovely introduction and background to the development of the intervention and the problem, and how we like the logic model of the problem and the logic model of the change. So that's quite clear now, I hope, that why we choose our primary outcome, which I will just very soon come to. So I have the honor to present the result of the randomized controlled trial of the effectiveness of the STEPSTONE transition program for adolescents with congenital heart disease. And wrapping up 7 or 8 years of work in 15 minutes is quite of a challenge. So this is really a scratch on the surface, and you're more than welcome to approach us afterwards to ask more questions and details. But the aim with this project was to investigate the effectiveness of a person-centered transition program for adolescents with congenital heart disease. So the outcome measures, as I guess you all know what the primary outcome in our trial was. We chose to use patient empowerment, and we measured patient empowerment with the Gothenburg Young Person Empowerment Scale. Of course, we have a list of secondary outcomes as well. We measured transition readiness using the Readiness for Transition questionnaire, and as you see, there are some sub-domains in this questionnaire as well. And we measured patient-reported health using the PEDS-QL, and I think Many of you are familiar with the PEDSQL as well. We also measured quality of life using a linear analog scale. We measured health behaviors using the health behavior scale and also disease-related knowledge and parental uncertainty, because we wanted to have at least one kind of component trying to address the parents as well. Even though this intervention is completely focusing on the adolescents, we had a kind of complicated or like a long discussion when we developed the intervention that we absolutely could see the needs of the parents, but we decided in the end that the intervention will be developed with the focus of the adolescent needs. But we try to at least have like part of it focusing on parental needs as well. So this was a randomized control trial, and we involved, and I want to emphasize the word involved, 7 hospitals in Sweden. From Umeå in the very north, this is my pointer, yes, to Lund, which is in the southern part of Sweden. And this is the design of the study. And I will try to guide you through this a bit busy slide, but more or less it was in this randomized control arm, we randomized patients at 2 centers, in Stockholm and in Gothenburg. And we randomized person on a person level to either go into the intervention group, where you got like usual care, of course, but in addition, you also went through the transition program. And in the control group, they just received usual care. But the problem is when we are performing these kind of intervention studies, is that in the same setting, in the same outpatient clinic, it's always the risk of contamination. I mean, it might be that usual care actually are a bit influenced of what is going on the other side of the corridor, so to speak, and we cannot really control that. But to try to control potential contamination, because this could actually violate the results, of course, we also added this third arm where we collected data from 5 other hospitals where there were no ongoing intervention study. And we collected data, as you can see here, at the age of 16, at the age of 17, and the age of 18 and a half years of age. And this is the person-centered transition program, as Philip already mentioned, so I will not go into details about this again. And again, of course, this is just a scratch of the surface. There is a lot of things to say about each component, but I don't go into the details. More than we just have to say and just confirm and echo previous speakers that the transition coordinator is absolutely the core in this transition program. The transition program, the STEPSTONES transition program, started at the age of 16. And I just want to mention, why did we start at the age of 16? And that's completely because research funding. We do believe, and we are completely convinced with the rest of you, I guess, that we have to start much earlier. But the reason or the explanation for us starting at the age of 16 was that you get research funding for 3 or maybe 4 years, and you want to kind of find a window where you can start and where you can also have the last measurement after the transfer to adult care. So that's the reason for this. So what we did, that we had a visit with the transition coordinator at the age of 16. The next visit was at the age of 17, and then we tried to plan a peer support group, you can call it, like an adolescent day or an adolescent evening in the age between 17 and 18. And then you had a last meeting at the 18 years of age, and that was also a joint meeting together with the adult care, because in Sweden we transfer the patient at the 18 years of age. So in summary, what was the purpose with the meeting or consultation with the transition coordinator? Well, we wanted the adolescent to be well informed about their health, cardiac diagnosis, the treatment and the follow-up. We wanted them to feel confident in their ability to manage their illness and the condition. We wanted them to feel, to develop better self-esteem and improve the ability to talk about the cardiac diagnosis. And we wanted them to take control over their health and illness and follow-up care and daily life. And also improve and develop skills to make well-founded decisions, because we know in this age that there's a lot of decisions they have to make about school, about future, about family planning, who am I, my identity, and stuff like that. So this is a summary where what we were aiming for with the consultation to the transition coordinator, using different kind of tools, of course. As Philip already mentioned, heads, we worked with goal setting. We tried to find and identify the resources of the adolescent and to strengthen and to empower them in this process. So what about the results? Well, just very brief, some socio-demographic and medical background variables. And these are the results from the randomized controlled trial, not from the third control group. So we had 55 adolescents in the intervention group and 61 in the control group. And there were no differences when it comes to CHD complexity, comorbidity, or whether or not they were born in Sweden. And looking into the primary outcome, we measured that in empowerment change from T0 to T2, and meaning at the age of 16 to 18 and a half year. And there was a significant difference between the intervention group and the control group, as you can see here. The blue boxes are the intervention group, and the white boxes are the control groups. And the mean change for the intervention group was 6.41 when it comes to empowerment. And the mean change for the control group was 2.97. And this was statistically different. And this was also confirmed when we made the analysis in the per protocol population and the intention to treat group. Going into the secondary efficacy variables, we could find a significant difference when it comes to parental involvement, and meaning that we saw a decreased parental involvement in the intervention group. This is what we were aiming for, of course. We also saw a significant difference when it comes to overall transition readiness, improved satisfaction with their physical appearance, which is a sub-domain within the PEDSQL questionnaire. And also quite an effect on disease-related knowledge, which is very much in line with previous randomized controlled trials. Going to the other secondary efficacy variables where we didn't find any significant difference was adolescence responsibility, health problems, heart problems, treatment anxiety, cognitive problems, communication skills, which are all included in the PEDSQL questionnaire. And also we didn't see any effect on quality of life, health behavior, or parental uncertainty. So what about the contamination in this kind of complicated design slide I just showed you? And we couldn't see any signs of contamination, which was, we were very happy for that, of course. So in conclusion, the STEPSTONES transition program was effective in increasing patient empowerment, reducing parental involvement, improving satisfaction with physical appearance, and increasing disease-related knowledge. But I just want to mention a little bit before we end this presentation. So what is the next step? And Philip already mentioned like the ongoing project that we have within the STEPSTONES consortium right now. And I just want to put a little bit emphasis on the STEPSTONES implement, because this is something that we have been discussing today, and I think we will continue to discuss what is the next step. How do we implement the transition program, make it sustainable and successful? So we started STEPSTONES Implement project, and just very briefly, the main purpose with this project is to implement an effective, sustainable, person-centered transition program for adolescents with special healthcare needs in Sweden. And the specific aim with this project is to implement the transition program using predefined implementation strategies at 6 different university hospitals in Sweden, providing special care for adolescents with special healthcare needs, and to evaluate the effect in terms of patient-reported outcomes. Because we also want to know, of course, we show that this program has effect within kind of a control project. But what is happening when we're trying to implement it in a real-world setting? Is it still effective? So that's one part of the first part of the specific aim. And we also wanted to evaluate the implementation process of transition program and the implementation strategies used to facilitate implementation of the program. We want to identify, if possible, successful implementation strategies, because we know that implementing, if you want to change a care model, it's quite challenging. We need to see what kind of key keys that we need? What are successful strategies to learn about how to make it sustainable and implemented? And also the third part is to explore the prerequisites for and adaptation of the transition program for adolescents with developmental and neuropsychiatric disabilities, because STEPSTONES right now focused on physical conditions, so to speak. We didn't put so much attention about the challenges for adolescents with developmental and neuropsychiatric disabilities, but we are of course completely aware that this group of patients have specific needs as well, so that hopefully within a couple of years we can come back and give some answers about that. What kind of successful implementation strategies did we find in this project? So, and as previous speakers said, I also want to acknowledge this is a teamwork. It's a fantastic team, and I know that there are at least 1, 2, 3, 4 here. Can you please rise and just say hi? Because it's Carina, Anna-Lena, Mariela, Sandra. So please say hi. And there is a lot of team members that are not here, of course, and there is a lot of other people not mentioned here because this is a huge program. But this would absolutely not be possible without this fantastic teamwork, of course. So thank you very much for listening.
Thank you very much. I didn't even have to wave my cards. Thank you. Are there any questions? Because I have a question, because you started with an idea about the components, the ingredients. So could you give us some idea, what is the most important ingredient of all?
Well, this afternoon I will present one of Markus Sarjärvi's abstract. Unfortunately, he will be not here. He couldn't attend, so I will give his presentation. I'm very happy for that. But based on his process evaluation, we could actually at least get one step closer to try to understand the mechanism of impact in the transition program. I think this is in line what we have been talking about. What kind of ingredients or components are actually effective? But if I should say one thing, the transition coordinator is absolutely crucial. That's absolutely what we very clear could see.
Okay, that's already helpful for our workshop in the afternoon. Thank you very, very much. Okay.